Present.
And Commissioner Christian.
Present.
All right, welcome. Thanks everyone for your patience. I'll read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on traditional territory, traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the consideration of approval of the February 24th, 2025 minutes.
So commissioners, the minutes are before you and we're prepared for a motion.
Move to approve. Second.
Is there public?
I'm checking to see if there's public comment. Oh, actually, is there any public comment in the room? There's been no one who's been given remote public comment permission. So all those in favor of approval?
Aye.
Aye.
All right, great. Thank you so much. We can move on to item 3, the regulatory affairs report.
Good afternoon, Commissioners. Emma Moore, Director of Regulatory Affairs, here to provide the March 2025 Regulatory Affairs report. So first up, under pending surveys, it is the same list as last month. There's been no major activity. I think the one thing to note is that our Joint Commission Stroke Survey was supposed to happen by next Wednesday. And between the 7 days notice that they typically give us, in addition to the blackout dates we are still allowed to provide since it's a certification, it appears they will be coming past our window. So at this point, my crystal ball has gotten very foggy because they were supposed to come by next Wednesday. So we will be continuing to be ready. The nice thing about this, again, is they do typically schedule it a week in advance. So units have already kind of been on alert and we will have time to sort of do final rounds and make sure everything's ready to go. In terms of survey activity, you can see at the end of February, there was a bit of an uptick. So first, CDPH came out to do strike monitoring for the UCSF, AFSCME, and UPTE labor action. There were no deficiencies found during that survey, and we do expect that they will be back out next week on Tuesday because we've been given notice that there will be an additional one-day strike on April 1st. Secondly, on February 27th, the Department of Social Services came out to the Behavioral Health Center and did the ARF, Adult Residential Facility, annual licensing survey, and there were no deficiencies found during that survey either, so that went very well. Moving to page 2 of the report, i.e. section 4, the CDPH cases, the facility reported events. You can see there that our year-to-date total is up to 17. And in February, there were 5 privacy breaches, 1 sexual assault allegation, and then 1 other, which was the strike notification that occurred. And I think to answer the question that I got ahead of time, thank you for that. I reached out to the Office of Compliance and Privacy Administration, who are the ones that manage the privacy breaches and kind of that process. And one of the biggest things that I wanted to highlight that they've become aware of is that year to date in 2025, more than 70% of the privacy breaches have come in through the SAFE system. So in 2024, it was only 20%. So there seems to have been a dramatic uptick in the volume that is coming in through that method, because I think they also can accept them via email, phone, in person. There's a variety of methods, but the SAFE system seems to be potentially causing an increase in reporting. So not necessarily that there's been an increase in the number of total events, but from an identification standpoint, more of them are getting to the privacy office because of the SAFE system. Their other kind of look in trying to look at tracking and trending and root causes. They believe that the increase in breaches is possibly due to increased admits as well as ED visits and clinic visits, because they've been seeing more patients receiving wrong paperwork, and they think that there may be some pieces just in terms of the volume that's happening right now, I think with surges. And they are continuing to monitor both that near misses as well as the identified root causes. And in terms of kind of how they're moving forward from an action plan standpoint to try to prevent this uptick from being a steady trend and instead hopefully just be a blip, they've been meeting with the nursing directors as well as communications to develop a communication plan to best get to the relevant staff. They've been having articles in the Daily Digest going out about best practices related to privacy. They've been conducting in-person and virtual trainings for targeted areas such as the emergency department, med-surg, and some of the specialty clinics where a number of these breaches have occurred from an education standpoint. And lastly, they have done a privacy presentation with an emphasis on best practices for the UCSF service chiefs and administrators. So they're continuing to work on this. It is also my understanding that they will be coming to PIPS, the ZSFG PIPS, in May. So I think in June, there will be a much more detailed report about privacy breaches. And moving on to the next page, page 3, section 5 of the report, the plan of correction monitoring data, I think will be discussed in greater detail in the PIPS minutes, but things are moving forward in that regard. And in terms of the last 3 pages of the report, 4 pages of the report, in the spirit of simplicity, there has been no major movement on investigations by CDPH. Thus, these graphs look virtually identical to the way they have for the last several months. So with that, I will pause.
And there's no public comment.
Thank you very much. Commissioners, questions on the regular, Commissioner Christian?
Thank you. Good to see you. Can you just give me a little more or go over again a little bit more regarding the privacy breaches, misdirection of information? Did I hear that correctly?
Sure. So in at least one of the 5 that we reported in February, they failed to do 2-patient identification and misidentified a patient and thus gave them the wrong after visit summary. So I think that's.
I just want to stop you. Can you elaborate a little more for me? 2-patient identification.
So they didn't check that it was the correct patient, that first name, last name, date of birth, and consequently, when they went to pull the after visit summary, it was not for the correct patient. So they handed them the wrong information.
So first name, last name is the 2.
First name, last name, and date of birth.
And date of birth. Okay, the name and date of birth. 2-patient. Thank you for explaining that to me. Okay, thank you.
Is who's striking April 1st?
AFSCME and UPTI. It's the someone here I'm sure has a better explanation, but it's, I think from a realistic practical standpoint, it's respiratory therapists, the anesthesia techs. So it's UCSF employees. I believe on the list I saw there were, I think, 615 of them at the ZSFG campus, but I think from the last strike, I remember seeing a statistic in the news or a number in the news that it was like 57,000 people covered by those 2 unions at these relevant locations. And so this will be the 3rd strike they've had in the past 5 months. There has to date not been any significant impact on operations. So I have no official word as what next week will look like, but I'm cautiously optimistic that it will be similar, and we will be prepared to walk. They typically send out 2 surveyors from CDPH, and they visit each of the UC campuses, and plus coming to us. And so cautiously optimistic that it will be smooth, and we're getting well versed in this. So, and their laundry list of things they like to see when they walk on site.
Great. What goes on in terms of citywide coordination when you really are concerned that it could impact acute care in particular?
Anybody want to take that? Yes.
Hello, Commissioner. Susan Ehrlich, CEO. So this, just to recap, this is a strike on UC. So it's a statewide strike impacting specific types of workers. The impact really is mainly on the UCSF health campuses. So Parnassus, Mission Bay, Mount Zion. And because we have, so much presence of UCSF on our campus, we have some impact. And as Emma mentioned, the main impact has been in our lab because the lab, as you recall, is contracted. The clinical lab is contracted to UCSF. So all of the staff are UCSF staff. Additionally, the other area that we've seen be most impacted is the OR because the surgical techs are impacted. So we've closed an OR typically during these last 3 strikes. And in truth, we've been planning for this labor disagreement has gone on for years. And so we've planned more than the last 3 times, but it's been since November. It was in November of 2024 and February, I think, of this year. We set up HICS. So we meet twice a day. and survey the impact on the hospital. But so far, the impact has been relatively small, and I feel that we're well prepared. The last thing I'll say is that UC generally requests injunctive relief for certain types of staff. And it's interesting, this is a request of the PERB board, and it's really varies. It's the same strike, the same people, but the response of the PERB board really varies. For those staff for whom there's injunctive relief, it means they have to come to work. PERB basically says you have to come to work, you can't strike. So that's been very helpful, especially in the lab. And there's replacement workers, but it's all organized at a UC level. And the last couple of times, the UCSF health campuses, they've reassured us they don't go on ambulance diversion, they're not, having an internal disaster, they're able to function. And this one, because it's a one-day strike, it should be relatively easy to manage.
Thank you.
Hmm?
Well, thanks for that explanation.
Sure.
We had the Joint Commission at our place Wednesday, Thursday, and Friday, so I don't know if they hang in hoods, but just in case,
Okay.
we're definitely in this city on the end of last week.
Right. You had mentioned that you normally get a 7-day notice from Joint Commission now?
Only for the stroke survey. It's a certification, not an accreditation, so it's voluntary in that sense. And so they, in the spirit of collaboration, and I think we're the customer, because they want us to continue, are able to give us 7 days notice. So typically they will send an email, put it on the website, and we start going. But for the triennial full hospital accreditation, they absolutely do not do that. I wish they did.
Well, what's the difference that we're doing here?
So this is just our stroke certification service.
Oh,
So
the stroke
yeah,
certification.
It's 2 days, one surveyor, and it typically is more of a showcase
Sure.
of the
No,
wonderful stroke care that
I-
we're providing.
I got you. I didn't realize this, we were talking about stroke and
No.
not the full,
No.
right, okay. Because I thought they might have made a change in their policy.
They now no longer even put it on our website at 7:30. They walk in the door, CMS cracked down on them. So
Oh,
It's-
okay.
it's made an adjustment in the other direction.
Oh, all right. Thank you very much. There are no other questions, so we'll move on to our next item.
Okay, thank you. Item 4 is the hiring and vacancy report.
Good afternoon. Kim Knox Mitchell, HR Ops Manager for ZSFG. You have our report in front of you. So as always, I'll just share some highlights from the report with you. The total hospital vacancy rate for February was at 7.23% for authorized and 1.54% with attrition savings, compared to the January number, which was 7.68% authorized. So we had a small decrease there. We hired a total of 33 employees between February 1st and February 28th in various classifications, including RNs, and had 3 separations during the same period, of which none were retirements. The RN vacancy rate is at 4.7% for authorized and 0.70% with attrition savings. We continue to make ongoing efforts to address and mitigate challenges within our nursing recruitment. And some of the things that we've done is we've sought to make it a little more streamlined and remove some of the barriers that seem to have delayed our process in getting time to fill. We continue to do those. We also have provided, in addition to that, we've provided additional safeguards to ensure compliance with CCSF and civil service rules. Our analysts will continue to maintain oversight by auditing all hiring engagements. These processes changes aim to reduce time to hire and improve the experiences of our hiring managers and candidates with an ongoing focus on diversity, equity, and inclusion. A few more highlights. Our nursing leadership submitted a proposal for a critical care training program cohort. We have 22 nurses were hired at ZSFG in February, including reassignments, and we had 4 P103 per diem nurses hired last month to fill gaps in vacancies. And also, just an added, Commissioner Green, I know you asked before about our BHC hiring. There are efforts to enhance recruitment for behavioral health positions across DPH that has increased significantly. These positions include support for our street teams as well as in-person roles at city jails. This week, we are hosting 2 informational sessions for hiring managers to discuss with eligible candidates the available vacant positions, what our systems of care are, and why these are great places to work. Additionally, on Friday and Saturday, we will hold hiring events for final on-site interviews with candidates. Our goal is to have the selected candidates start mid-May. In partnership with sfgov.tv, we've also developed 5 recruitment videos that showcase our system of care, benefits, and employee experience. So we'll have more to report out on that at next month. Some updates on our RN hiring status. Our emergency care unit has made 4 selections with a target start date in March, April, and May. Our critical care unit has selected 3 with the start date the end of March. Our med surgical unit has selected 12, and those will start by the end of March. And our OR unit has selected 2 with the start date the end of the month. And some additional highlights in non-RN hiring. We've hired 2 healthcare billing clerks, 2 hospital eligibility workers, 1 pharmacy technician, 1 healthcare analyst, and 1 dental aide. And that concludes my report. Any questions?
Thank you very much. Or is there?
There's no public comment.
Okay, commissioners, any questions?
Thank you. No question. I just wanted to thank you for the information you gave about the hiring and diversity and looking for the correct people
Yes,
and giving everybody the opportunity to hire the best person available.
absolutely. Absolutely.
Thank you.
My pleasure.
Thank you. President Green, any questions? No, so I'll ask one. In terms of the non-RN hiring, what is the process in which with the city freeze that we can hire these, or were they pre-approved or some sort of classification that they fit?
So I'm not sure if these were pre-approved prior to the freeze. I'm not sure. I can find out for you. And I'm hoping that either Kim Walden or Risha is either online and can answer more questions about the hiring freeze.
Unfortunately, neither are on there. Oh,
Chief Nursing Officer. That classification was actually exempt from the hiring freeze, and so we were able to continue with the work that we've been doing with our HR partners.
Oh, so there are classes like within healthcare and so forth that we are
Correct.
able to hire in. Very good.
And
There
the
were
RNs, yeah.
Mhm.
Okay, well, I understood the RNs. I mean, that was,
There are also 6 other classifications that were deemed waived from the hiring freeze
Oh.
as well.
okay, very good. Thank you. We'll move on to our next item, please.
great. Thank you. The next item is the CEO report.
Good afternoon, Commissioners. Pleased to be here with you today. This afternoon, I'd like to highlight several of the equity-focused initiatives in the CEO report, and then take your questions before we go to the data. The first one is the Honeycomb Clinic. This is a really innovative clinic that was started by Doctors Danielle McBride and Ursula Griffiths Randolph in our Children's Health Center. And this clinic was designed based on the 2023 Black Patient Voice Project that interviewed Black families about their general experiences with the clinic. And from that feedback, they now have a situation, so for families who request it, they can pair a Black African-American provider with a Black African-American identifying family. And that has had some pretty remarkable results. It's increased the percentage of patients with 2 or more visits between 15 and 30 months from 19 to 31%, reduced the number of patients overdue for well child checks from 61 to 47%, decreased the no-show rate from 29 to 24%, and reduced the percentage of patients overdue for fluoride varnish from 87 to 70%. So this is really a remarkable effort incorporating these doctors' vision to improve the lives and health of our families in Children's Clinic. The second thing I'd like to highlight is our ED triage task force. And this task force has been working for quite some time, and its efforts were born out of our persistent challenges with patient boarding, mainly in the emergency department. And this task force has been working diligently to ensure timely access to care in the ED. There are many things I love about this task force, one of which is that it's really incorporated frontline staff voices and patient voices into the design of the care. So the work has involved many things like redesigning the space to make it more patient-friendly and to make it more staff-friendly. And we've hired nurse practitioners, especially working overnight, to operationalize their ideal staffing model and to address specifically leave without being seen. So this has allowed them to drop the leave without being seen rate to an impressive 2.7% so far in March, 2% being the best practice standard, and it was 5.8% in January. And I really want to thank the team here. It's led by Dr. Toph Peabody in the emergency department, now the medical director of our KPO, nurse practitioner Jeannie Hoffman, nursing director Mirja Roca, nursing director Dave Stakonis, and our lead nurse manager Matt Talmadge. They've been working really hard on this, and it's really starting to show results. And the last thing I'd like to talk about is our new Mammovan, which is very exciting. At the Hearts in SF event this year, we had an exciting announcement from Hydra Mendoza, who's the VP and Chief of Strategic Relationships at Salesforce. And so on behalf of Mark Benioff and the entire company, Hydra announced a gift of $1.66 million to buy a new Mammovan, which is really important to our operations there, because what the Mammovan allows us to do is to go out into communities where we know there's higher rates of undetected breast cancer, and to get to those women, get them screened, and to to hopefully prevent cancer overall, but definitely to treat it sooner. So we're obviously very grateful to Salesforce and the foundation who facilitated the gift. So those are the 3 things I'd like to highlight for you. Any questions about that or anything else that was written in the report before we go to the data?
Fine. Commissioners, any questions at this? Yes, Commissioner Green.
Yes, this was a great report. 2 questions. How many of the children that are seen through the Honeycomb Clinic have actually delivered at the general, and what is being done to coordinate the prenatal care and the families when they first enter their care, with an understanding and knowing about this option when they're at that stage with pediatrics?
Well, I'll say something general about that. I mean, generally, we have an effort going on known as Solid Start that really tries to improve care for our youngest patients before they're even born, and then through the age of 3. That is an effort that's been going on for a while, that is between our OBGYN, pediatrics, family medicine, and psychiatry. So we do have efforts to try to bring all this care together. The specific answer to your question, I do not know, and I'll need to get back to you. I've never heard anyone talk about that, but it'll be interesting to find out.
It's all these portals of entry we have, and if any door we can show families, especially at the outset, would be great.
Right.
The other question I had is, the U.S. Preventive Services Task Force recommends that you don't start mammograms till 50 and you get them every other year till 74 and stop. And I think most of us agree, especially in higher risk, especially African-American women have a higher rate of triple negatives and get diagnosed younger and so forth. Do we have any issues with either, Medi-Cal covering the mammograms, or having people hear these recommendations and then feel that they don't really need to come in. I mean, a lot of women have heard, the various recommendations from the task force that may or may not be. I mean, they're blanket. They don't really segregate any of them based on populations and risks, which is really unfortunate. So I'm just wondering if, some of the issue of having individuals come in may relate to this confusing information.
I'm not sure about that. What I do know is that we have statistics showing that women in the Western Addition, in the Bayview, and in the areas where we try to really focus sending the mamma van are less likely to show up for care, less likely to get the screening that's recommended, even at the 1 to 2 year for 50 and over. So we're trying to provide access to women who are in those categories. I'm not sure, again, I'm not sure about this specific answer to your question. I'm not sure that we keep those data. What are women's attitudes about screening in these high-risk groups? I can try to investigate that a little bit more.
Well, I mean, don't go to an extra effort, but I mean, it is kind of interesting when you try to figure out something that's in the, common parlance like mammograms. It's not a new test or something people are unfamiliar with, and yet we still struggle to have people follow through, and they become more and more accurate as time has gone on with 3D mammography and so forth. It's just such an opportunity, and whether people are afraid of radiation, which is minuscule, or what the issues might be, would be really interesting to learn. I mean, I think it cuts across all populations that we see, really.
Yeah, I think for this group, it's more, real specific issues that keep them from coming in as opposed to the attitudes. So meaning can't get a ride, have to work, have to take care of kids and elders. It's that kind of thing that keeps them from coming in that we know about. And so that's why we go out to them to make it easier.
Well, it's really interesting. We talk a lot about childcare and about this plan at Laguna to have childcare, and I think one of the real reasons young women don't come into medical checkups as they should is lacking childcare. I know they've done some studies for obstetrics where they've made childcare available at every obstetrical visit, and the adherence to the compliance in terms of keeping appointments really goes up. So it's of course, that transportation, but the childcare I think is a huge issue for people. And they probably say, gee, I don't know if I can't bring my child if there's radiation. It's just kind of an interesting question. I think maybe people don't realize it takes like 5 seconds to get a mammogram. But well, I'll be curious to know what kind of follow-up we get and the utilization of the van now that it's back on track. It's wonderful that we got that great grant. It's so important. So thank you. And by the way, UC was the originator of the mammogram ban back about 40 years ago. Ed Sickles was the first, I think, in the country to conceptualize the mammogram ban. And so I think it's a homegrown opportunity that's really obviously served its purpose.
Great. Well, we're happy to be able to continue the service for sure.
Commissioner Christian?
Thank you. Good afternoon. Good to see you. I just wanted to highlight how important I think we all feel, but I'll certainly speak for myself, the equity work that you're doing, focusing on reducing barriers and providing better treatment to everyone who comes through our doors. And it's continues to be impressive. And the data-driven nature of it, I think, is really important to emphasize, particularly publicly when people question drives for things that are focused on equity and inclusion. They're not understanding that it's about access and justice and just access to treatment, the same level of access that people in different situations have. And so it's just really impressive work and so critical. I wonder if this is the Honeycomb Clinic project specifically. Does this provide a kind of a template for you to look at other populations who may also be experiencing these kinds of a lack of access?
Yes, potentially. So recall that this came from specific feedback from patients
Yes,
about their experience.
yes,
It's
exactly.
actually similar to what happened in the emergency department. Getting specific
Yeah.
feedback from patients through real-time surveys that allowed us to address things like, just simple things like putting a charging station in the emergency department waiting room because patients were waiting so long, their phones would run out of charge. Putting more seats there. So I think, the principle is, let's ask our patients what they need, what's most important for them. Yes.
I definitely connected those the triage task force as well to these comments. And when you say real-time surveys, what do you mean?
So we have the ability through our, so we use NRC as our patient survey, right? Typically,
NRC being
NRC, I don't know what it stands for, it's a company.
a company. Okay.
So, and that's the company we use to elicit patient feedback about the services we provide on the outpatient side and on the inpatient side. And that we see in our HCAP score and our CGCAP score. In the past, and still is true with our inpatient surveys, these surveys were mailed, making it almost impossible to get, a sufficient number of surveys back from patients to get, to make real conclusions from the data. The real-time survey is literally a text message that's sent to patients right after they get care. So in the ED, for example, they get a survey as they're leaving or just thereafter. And in this case, we can actually specifically ask them questions about specific changes we've made to get feedback. So it's
Great.
very powerful.
Yeah.
Not only does it bring in way more responses, but it allows us to ask about specific things. It also allows us to get patient interest to do even more feedback with us, should they choose to do that.
Great, great. And, I also just want to acknowledge the obvious that, increasing the access at a center, at a place like the Children's Health Center, you are focusing on increasing the health of our youngest citizens, and it is so fundamentally important. I just wanted to recognize that and thank you so much for the innovative work that you and your colleagues continue to do and the way that you continue to think about the problems and how to solve them.
Great. And I do want to give credit where credit is due. This is a primary care clinic on our campus, right? We have 4 of them. So this is within the primary care division of the San Francisco Health Network. And what's different about our primary care clinics as opposed to the ones that are out in the community is we have UCSF faculty staffing the clinics and we have residents in the clinics. So this specifically was a partnership between the UCSF faculty and the Children's Health Center Clinic, which is part of the primary care division. So I just want to make sure everybody understands where the credit should be assigned.
Well, thank you for drilling down on that so that we're mindful of that. And thank you for, again, being willing to give the credit where credit is due.
Sure.
Thank you.
Thank you. The Honeycomb Clinic, I think, also demonstrates that, as has been shown in other studies, that if you have providers who are, I would say, sympathetic and who, frankly, say in the research that they look like them, that you will get better compliance. And I think it's great that you're able to do that. Seems to me in the fluoride varnish, because I look at that because the data is not good in parts of the city, that I'm sure you wanted to get better from 87% to 70%, because that means 7 out of 10 kids still have not gotten fluoride. Is the impediment there dental services, or is the impediment really reluctance? Because with that kind of a group support, one would hope that we would get even better compliance on.
Well, so I just want to make sure we're clear. This is the percent of patients overdue. So it doesn't mean
Yeah.
that they don't get it at all. It just means the percentage of patients overdue. In terms of the barriers that, make these numbers so high to begin with, that's something I'll have to get back to you on. I don't know what I mean, it's not dental services per se, because it's the medical assistants who are applying the fluoride varnish by and large. So it's not about dental services. It's more about other things, but I would need to get back to you to know what they are.
No, I think you're correct. The practitioner is supposed to be trained to be able to administer, or the office administer, the fluoride. So seems to me that it'd be interesting and important to understand what the barriers are if it was not an issue of being referred to another clinic. If they're at our site, then what were the reluctances, and therefore, what are the possible, as you put in, countermeasures to really give them, and it might be educational, it might actually be, again, the data that shows improved scores in schools and whatnot, whatever that may be, because I know the citywide dental, the fluoride issue, has been in place for a good number of years. So I just think that, as you say, even though they're overdue, seems to me that they haven't gotten it yet, that we should try to drive that number down, because they are people then who have come, and that we're able to really, be the right door for them to get it, if we can find out why they're reluctant to get it.
Now you've made me curious, Dr. Chow. We'll find out more.
Okay, I think the other, and thank you for the update on the Walgreens issue, is that in the next several months, if we can get data from our pharmacy there on the outpatient basis as to how well we've been able to cope with the closings, that would be very helpful.
Yes, so we just gave you the impact on our outpatient pharmacy, but there are bigger impacts on patients that Dave Smith, I think, will be able to provide for you at another time.
Okay, that'd be very good. Thank you.
Sure.
Shall we go on to our next item then?
I believe there's data.
Yeah, there's data.
Oh,
You know how we love data.
okay.
So this month, and this month only, I'm going to be presenting the flow data, because the True North data is going to be in the next item. So just to be clear, this is less data than you typically have. And I just want to summarize the data that you do see. So first of all, in slide 1, after the steady rise that we had in ED volume since August, it's starting to level off at a pretty high rate at 203 patients a month. On slide 2, you can see that our PES volume remains pretty high, which is good because it reflects better flow into the inpatient unit and to other places. On slide 3, inpatient admissions continue to rise, and they are at their highest level since March of 2023. So that is obviously very significant for us. Skipping to slide 5, inpatient admissions to psychiatry are rising pretty steeply and are at their highest level on this chart, which again reflects better flow into the inpatient unit, which is good news. On slide 6, correspondingly, our psychiatry inpatient length of stay is declining pretty steeply as well, also reflecting better flow. Unfortunately, med-surg inpatient length of stay is at its highest level on this chart. So totally opposite situations. So that is not good, and you'll hear more about what we're doing to try to address that in our strategy presentation. On slide 7, lower level of care continues at a low level for psychiatry and persistently high for med-surg. And then on slide 8, I can say, fortunately, transfers to Laguna Honda are picking up. Just sharing a little bit more data than what you see on this slide. These data show 5 transfers during the last week of January. As of March 19th of 2026, Laguna Honda had accepted 72 of our patients since they began taking our patients on August 26th. Time to consider these transfers, the goal is 2 days, is just over 6 days in February. So it went down to 4.5 days. Now it's up a little. So that we'll continue to work with Laguna Honda on. And it's important to know that our care coordination team and Laguna Honda's care coordination team are meeting continually. I meet with Diltar every week. We're working very hard to try to address this flow issue. So it's good, it's better. We still have work to do, but it's generally, working okay. Any questions on the data that I presented so far?
Any questions?
Yeah, I just had one about the pediatric and OB numbers.
Yes.
And I had two questions. One was, I mean, I had two patients and a total of 3 babies transferred because your NICU was full. And so I was wondering how we do track units like that when you do have to transfer patients out. And of course, it's the mom and the baby because the NICU is full. And then I also wondered if the NICU admission was unanticipated, which is one of the quality parameters, whether if that baby doesn't get admitted to your NICU but gets transported, whether that still counts on the tally at the county or whether that case isn't part of the statistic.
Well, fortunately, we have Jillian Otway here today, who might know the answer to these questions better than I do. I know that when we are full, we go on telephone divert for the unit, but Jillian can give you the data about that.
When we are on telephone divert, that would probably be when the patients would come to CPMC. And obviously the delivery, we try to keep mom and baby together. And so I was not aware that the NICU was on divert last week, but I do know that labor and delivery was on divert. Because
It was on divert the last week of February.
Oh, last week of February, then yes, that is a possibility.
I'd just be curious to know how often, because it is such a big deal. I mean, talking earlier about moving people out of an environment where they're familiar and comfortable, and suddenly this mother and baby are thrusted into a completely different institution, not even close to where the county is. And I think, plus they've got all the stress of the baby being in the NICU. So I'd be curious to learn a little more about how often it happens and, what we're doing to try to improve that transition for these families. Most people, of course, do a hospital tour and everything else before they have a baby at an institution. Suddenly they're thrust at 3 a.m. to a completely different site where they really don't know the staff and they have no familiarity. I mean, if it's very rare, and I'm obviously one person's experience doesn't really reflect what's going on across the board, but if it's common that the NICU really does have to go on divert, it would be helpful to understand and maybe to try to work through some processes to make it easier on the families.
Yeah, we can get you that information. I know the last time we talked about this was in August, September, when our numbers were really high. And we also had a number of babies that had been with us for an extended period of time due to the fact that they were withdrawing. And so we can definitely get that information. And again, we try to make it as comfortable as possible for mom and baby. And usually what happens is we'll transfer both to the accepting hospital.
Yeah, well, that's exactly why I knew about it, because I accepted the 2 moms, and one was a set of twins and another was a baby on the cooling protocol.
Yeah.
So, yeah, well, thank you.
Just to follow up on that, how do we select which hospital to go to if we are on diversion? I mean, there's, you see
So-
just down the road,
Right.
in a sense, and then CPMC on the other side of Van Ness.
So if we are on divert, we would contact Kaiser, CPMC, and UC, and we would speak to them personally first.
Oh.
Because we can't divert a mom that comes in, but we will be able to tell a mom that calls on the phone, by the way, we are on divert, we're sending our patients to Kaiser right now. So we speak with them first before we actually give that information out to the mother.
So it's a phone diversion.
Correct.
And then the mother then finds her way to where you have been able to find a site.
Correct.
Yeah, these were transferred from the county. to
If
us.
it's a transfer from the county,
Yes.
then obviously we would contact the accepting hospital, and usually UC is our first choice because of,
Not your first choice?
well, only because of the baby, and usually the baby needs that level of care, tertiary level of care.
Wait a
So
minute.
we have an agreement with them, so they're usually our first choice. And then if they're unable to accept, then we would go ahead and contact you. So
Thanks.
Okay, Commissioner Christian, oh, no, okay. Let me ask one question in regards to this throughput on lower level of care and the exciting news of how psychiatry actually was, after all these years, found a way. So what was the secret to say that psychiatry was able to actually open up beds for acute cases?
You know, we have discussed this because you can imagine that we would all be curious about what is different. And I think it really comes down to two things. We don't have a way of knowing specifically what cause and effect is, but just based on timing, it seems there were two main root causes. One is the investment in beds that BHS has made. There are just more options for patients to be moved to. And the second thing that really helped a lot was having our own BHS expert be internal to ZSFG. That's our chief integrative officer, Angelica Almeida. This started happening right after she came and came to our executive team. So having somebody who really understood how to work with BHS, who understood the intricacies of placement for different patients, what the options were, and were able to effectively partner with BHS on this was very helpful. So it was really that combination of expertise and partnership with the resources available.
Oh, very good. It's obviously a specific skill, therefore, in regards to the specialty, rather than getting back on the other side of the chart where we have our flow problems.
Right. Well, recall that in the patients who are moving out of psychiatry who need a placement are being placed into places by and large that are paid for by our BHS. Right. So in some ways, bless you, it's simpler, or it's more of a closed loop system. Whereas on the medicine side, there are many different placement types and many different things that need to come into play, like, you know, a decision maker or a conservatorship or a skilled nursing bed in many different places, or resources that need to be put together at home. It's just a broader spectrum of things that need to be managed by many different players.
Oh, very good. Any other questions? If not, we'll move on. Are we ready to move on?
Are you done with the data? Great. So
Okay,
much.
thank you.
Let's move on to item 6, the 2025 Hoshin update, and I will pull up the presentation.
Good afternoon, Commissioners. I'm Hamil Kanzaria, the Chief for Performance Excellence and an emergency physician at ZSFG. I am very excited to share a report on our strategic planning and deployment process, or HOSHN, as we call it in lean terminology. This is, I believe, the 7th year that we've had this increasingly rigorous process around strategy. And this past year, facilitated by the Kaizen Promotion Office, the executive team conducted an environmental scan. We went through a number of study adjust working sessions where we looked at the challenges and the successes of this past year. And then together with many others across our campus and outside, decided on priorities for the upcoming year, which we're going to go through. The strategic planning process from this past year led to a pretty significant evolution, especially in our flow, patient safety, revenue strategies, with purposeful sort of alignment around behavioral health and inclusion of behavioral health. So we continue to monitor these strategies very frequently. Our executive team spends a lot of time every week sort of thinking about this and engaging both staff and patients across the organization in this process. So the following presentation is a summary of some of our successes from 2024 and a review of the process that we employ in this. I wanted to mention that I'm incredibly grateful to the KPO at ZSFG that supports this work, and Chris Ross is going to speak with you all today. And I'm also incredibly grateful to my executive colleagues who lead this work and always bring compassion, persistence, humility, and just great leadership to drive these impressive outcomes. I think it's one of the things that makes ZSFG, and sort of my opinion, the best safety net hospital in the country and in the world. There's a slide on terminology, and I don't know if the slides are up anywhere.
Oh yeah, I'm sorry. The light bulb keeps going in and out. I think it's running out of steam. So I apologize. The commissioners can see it and folks
Okay, no
online
problem.
can see it.
So there's a fair amount of terminology in lean, and I just want to simplify a little bit for us. These are all terms that you're going to probably hear over the next year or have heard before. For today's purpose, I just want to highlight that HOSHN is basically translates to policy deployment and is simply our method of strategic planning and deployment. And the second term for today is key performance indicator, or KPI. And these are really the metrics that we track to determine if we're having success or not on our high priority initiatives. And ideally, this is in the next 1 to 2 years. I think we are going to highlight some KPIs today that I anticipate will potentially last for longer than that because there's work to do. The next slide sort of shows and reviews some of our recent successes from our strategic process, of which there have been many. Essentially, we've had success on all of our strategies over this past year. So in terms of flow, we comment on work that peri-op services, psychiatry, the emergency department, and the Department of Care Coordination have led that have allowed for greater access to care for our patients, improved throughput, and less waiting for our patients to get to the next step across multiple areas of our organization. I want to highlight that our revenue cycle team and our denials task force have championed a 12% relative reduction in denied hospital billing days over this past year. Our patient safety teams have almost eliminated hospital-acquired pressure injuries over the past year. And then I'm really proud of our equity work, which has gone from 5% of our departments in 2015, driving quality improvement with an equity lens, to 78% this past year. And so numerous successes that we take into account, and knowing that we still have work to do. And so now I'm going to turn it over to Chris, who's going to go through the process, and then to our executive team members who are going to go through some of the updates on the KPIs.
And Chris, as this goes out, you can look at this to see where we're at, because this will go in and out.
Perfect. Thank you. Hello, Commissioners. I'm Chris Ross. I'm the Director of the Kaizen Promotion Office at ZSFG. At ZSFG, our strategic planning process occurs continuously throughout the year and follows the 7 steps on the next slide. At a high level, this process follows the Plan, Do, Study, Act continuous improvement methodology. And what this means is that over the course of the year, as we're deploying our strategies, we're constantly studying, adjusting based on data, trends, changes to internal, external environment, as well as guidance and direction from DPH leadership. Annually, our KPO team facilitates a series of sessions with the exec team that we call HOSHN. The goal of these sessions is to study the impact of the past year's strategic plans and to set forth goals for the next strategic cycle. Today, we'll share highlights of this process as well as our strategies for 2025. Next slide, please. So our first phase of our strategic deployment cycle is the scan phase. In the healthcare context, this phase involves assessing the current state of the healthcare organization. So when we go through this, we conduct a SWOT analysis, which is a strengths, weaknesses, opportunity, and threat analysis, to really understand what are the changes in environment, both internally, externally, as I mentioned before. We interviewed a lot of our leaders at ZSFG, as well as leaders across the network and DPH, really to understand where we're exceeding, as well as where we have opportunities. As part of this process, we include a lot of data. We gather data on a range of items, including, for example, community and city needs, influence on our hospital quality ratings, patient and staff feedback, trends and existing metrics, all of which inform the direction of our strategic planning and revisions needed to our current strategic initiatives. The outcomes of this scan phase is a set of business implications that the exec team agreed upon, including into our next round of strategic revisions. So this goes into our next phase, which is the plan phase. This is where we take the insights, the analysis from our scan and incorporate that into our strategic initiatives, which we call our strategic A3s. This step also includes the revising of our annual goals. So for meeting target, are there goals that we can retire? If there are goals we want to keep trying to push and exceed, resetting targets for those. And then as Hemel mentioned, for this year, we revised a couple of our KPIs to be a little broader, really to address some of the root causes to our flow patient safety opportunities. These revised strategic A3s and goals are then catchballed, which is a term we use for kind of this dissemination, communicating what our plan is with a lot of the operational owners, a lot of leaders at ZSFG to get their feedback and advice. As we go through this process, this trickles right into the do phase. So this is how are we going to do some of this work? Some of the key points in our do phase is setting up the infrastructure to drive this work. So setting up multidisciplinary cross-functional teams to help support this work. So we know a lot of these issues, they're very broad, they're complicated. One department, one individual can't do that alone. So this is currently where we are, is setting up that infrastructure, aligning folks, aligning teams, as well as setting up project plans. So how are we going to sequence out this work for the next few months? And you can go to the next slide. So this is a summary of the outcomes from our HOSHN process. Our 4 strategic initiatives haven't changed in title or their focus, but some of the scope and their measurables have changed. So you see that middle column, this is our set of annual targets for the next 12 to 18 months. And this visual demonstrates the alignment of these annual goals to our long-term outcomes, such as our patient satisfaction, staff satisfaction, and star rating. So next we'll hear from the exec owners of each of these strategies to share a little more around some of the revisions to the KPIs, as well as sharing what our goals are for the next year. And we will start with patient safety.
Good afternoon, Commissioners. Adrian Smith, Chief Quality Officer and Patient Safety Officer. So our 3 chosen metrics for 2025, we've honed our falls goal to look at falls with moderate and major injury. That was multifactorial, but it was really to look at what affects a patient's experience and a patient's journey through healthcare. It's a very small number, so we're hoping by being able to spend more time looking really much harder and putting a lot more focus on a smaller amount of events, we're able to change things. We continue to look at sepsis bundle compliance, and we're adding medication for opioid use disorder as our 3rd patient safety metric, specifically looking at buprenorphine prescription at discharge. The baseline data comes from the ACT team for inpatients, but we'll be expanding that to include the ED and DF over time. Our falls with moderate to major injury is off target, but we're hoping with that focused work we can continue to improve that. And our sepsis bundle compliance, we saw an encouraging rise in compliance, but it doesn't seem to have been sustained, so we'll continue to study that. And then when we think about countermeasures, we've talked about some of them. To answer some of your questions specifically about MOUD, my ability to print and then pick the pieces of paper up and bring them with me appears to have failed, which is why I have my phone in my hand. There was a question about MOUD. We're at the beginning of the process. We're bringing together a group of stakeholders. So we are really just looking at data collection today, but we know in our partnership with CORE and BHS that there are many interventions that we can add to what we're already doing to do that. You asked it about how aligned we were with the work citywide. We have active representation in CORE and active representation at network level, and we continue to have those conversations to make sure that we are implementing cascading metrics and metrics that complement one another as we begin to do this work. I'll pause there and pass it on to the next executive.
If you can go to the slide after the countermeasures, the next slide.
Good afternoon, Commissioners. Gabe Ortiz, Chief Medical Officer, proud co-sponsor with our Chief Nursing Officer of our Access and Flow strategy. You can see here the transformation that this strategy has undergone as a result of the Hoshin process that Hemel and Chris have laid out. Really, it's been a really valuable process for thinking about access and flow more holistically. We've reframed the strategy to be more comprehensive of the system science factors that really play a role in access and flow, things like inputs, outputs, and our care processes that occur across our organization. In addition, the other really big transformation here is that our strategy we really asked ourselves or challenged ourselves to think about which areas are really the key bottlenecks across our organization, and let's make sure that those areas are really prominently represented. So you can see kind of two bottleneck areas represented here in terms of adult medical care as well as inpatient psychiatric care. And so kind of some of the rationale around how the Hoshin process transformed how this strategy has been reframed. Within the strategy summary table, you'll now see that there are two kind of big overarching strategies. There's the right care, right place strategy that's really focused on the inputs into the hospital system. And then there's the clinically appropriate length of stay that's really focused on the care processes themselves and the outputs. Within right care, right place, and clinically appropriate length of stay strategies, you'll see two lines for KPIs. One that represents adult inpatient medical care and a second line that represents psychiatric care. So in the right care, right place, the selected KPIs are more of a reflection of care in the wrong place. So kind of in terms of those inputs, the way we're thinking about the strategy is kind of let's make sure that we bring in patients that belong in our setting, in our healthcare organization, and think about, are there alternate ways of caring for patients that makes the most use of the resources available, or actually redesign the care altogether. And you'll see some of that represented in some of the subsequent slides as I talk about the run charts and the really innovative work that our team is taking on. But within right care, right place, we're really focusing on a defect metric, for lack of a better word, kind of number of patients boarding in the wrong place, waiting for a bed somewhere else. So for the medical side, it's the number of patients boarding in the ED, the ICU, or the PACU. You'll see the baseline is 34. We would love to get that down aspirationally to 0. We're targeting 15. For average length of stay of boarding psychiatric patients, it's really a measurement of how many hours those patients spend in psychiatric emergency waiting for an inpatient psychiatry bed. Our baseline is 72 hours. We would love to also get that down to 0. And our target is 57.8 hours. For the second overarching strategy, clinically appropriate length of stay, again, focused on our care processes and outputs. We're looking at length of stay on our hospitalized medical patient days. Our baseline is 6.1 days right now. Our benchmark, which is really drawn off studies of other safety net hospitals, so trying to compare apples to apples. The AHRQ has a healthcare cost and utilization study that we use to kind of use to establish our benchmark. So the benchmark there was 5.1 days, and we're open to continuing to think about that benchmark. We're aiming to reduce length of stay down to 5 days by the end of the year. And then in terms of the psychiatric parallel, we're looking at inpatient psychiatric acute days. So the percentage of days that patients spend in our inpatient psychiatry units and trying to optimize those so that a higher percentage of those are actually acute days. So patients actually belong on inpatient psychiatry. Our baseline is 16.5% of total days right now are acute days. We'd love to get that up to the California state median, which is 44% as our benchmark. And by the end of the year, kind of incrementally increase up to 19.8%. So on the next slide, you'll see run charts for our first KPI. So this is our right care, right place. Boarding in the ED, in the medical ED, in the PACU, and the ICU for patients waiting for an acute inpatient medical bed. Again, our performance year to date, fiscal year to date is 34.5. Again, our target is 15, and this is off target. You can see that January was a particularly hard month with an average of 43 patients boarding. there are a lot of innovative strategies and approaches that are kind of aimed at bringing us to target. The first one I'll highlight is our teams have devised a dalbavancin antibiotic workflow. Dalbavancin is a new antibiotic. It's a long-acting injectable antibiotic that targets bacteria that cause skin and soft tissue infections. So we've deployed a workflow to be able to offer that to our patients and be able to discharge them instead of bring them to the hospital where they would spend 3 or more days receiving IV antibiotics. We've successfully dosed 30 or more patients at this point, saving over 100 hospital days. And so really excited about that work in terms of that kind of, again, that concept of right care, right place. We've already touched on the triage task force and the Care Start workflows to kind of get patients care very efficiently in the ED. And there are multiple other kind of countermeasures that are aimed at reducing the number of patients that are in the wrong place for care. So we're hopeful to kind of make some progress on this KPI. On the next slide, we have our boarding in psychiatric emergency. Here we aim to reduce the number of hours that our patients spend waiting for an inpatient psychiatry bed down from our baseline of 72 to our target of 57.8. Fiscal year to date, we're at 62.06 hours spent waiting. You can see a dramatic decrease here. We've touched on some of the reasons why, but a lot of it has to do with the outflow and the clinically appropriate length of stay KPI, where kind of we just have capacity to bring patients through PS and actually move them upstairs into the inpatient psychiatry areas. So some of the innovative work that's happening here is with this increased capacity in PS, now that patients are moving upstairs, we're trying to bring patients who are brought in by ambulance for mental health emergencies directly to PS and thereby create capacity on our medical ED to make the most use of the capacity that we're creating here by the other great work that's happening. On the next slide, you'll see as the second overarching strategy, our clinically appropriate length of stay strategy. You'll see the medical inpatient adult medical care length of stay. Fiscal year to date, our average length of stay is 6.5 days. We'd love to get that down to 5 days by the end of the year. So we're currently off target here. Again, lots of really innovative work happening. So we've expanded our operating room this year as one countermeasure. The expansion has targeted our patients who are in the hospital waiting for a surgical procedure. And in preliminary data, what we see is we've been able to decrease length of stay for those patients by a day and a half or more. And so by kind of targeting this resource aimed at and aligning with this KPI, looking to make an impact on length of stay, overall length of stay. We've done some innovative work with our lower level of care patients, which we know is one of the biggest contributors to why length of stay remains so high. Took the opportunity to cohort those patients over the last several months on one of our med-surg units. And today we learned a lot about what our teams have learned of the advantages of cohorting those patients in terms of mobility, in terms of the nursing care model, and in terms of being able to have those patients heal and sometimes even be able to heal to the point where they can return to the community rather than get stuck in the hospital waiting for a custodial facility. And much more kind of work, excitingly, to parallel what we've learned from our psychiatry length of stay. We know that those outputs and having a place to send patients is really critical. So we've been partnering with very closely with Laguna Honda and made some tremendous strides in terms of decreasing turnaround time for our referrals, where it was kind of couple of weeks. Now it's down to like 4 or 5 days for a decision on our patients. And very excitingly, by mid-April, we'll be reopening our 4A skilled nursing facility that will provide another disposition for our patients, and hoping that will further kind of help us make progress on our the length of stay of our patients on acute inpatient medical units. The last run chart is our KPI for our psychiatric care areas. You can see incredible progress here. Fiscal year to date, 20% of the total days spent on inpatient psychiatry are acute days. We're actually at goal here. Our target was 19.8% by the end of the year. So we've really made incredible strides. We've alluded to kind of some of the successes, but having access to places to send our patients, locked psychiatric facilities, and being able to leverage those, as well as partnering with our residential systems of care partners and finding community placements for some of our patients on our inpatient psychiatry units, have contributed. And kind of big shout out to our Chief Integrative Officer, Angelica Almeida, for leading a really great and talented team and being able to kind of drive this very meaningful and impactful change. And that concludes the 4 new KPIs in our reformulated access and flow strategy. So really right care, right place, and clinically appropriate length of stay representing those 2 key bottleneck areas very prominently within our strategy, and also inviting more teams to engage in the work. So I'll pause here and turn it to my next colleague, who will be focused on our next workplace violence.
Hi, I'm Angelica Jernigan. So I am the Chief Administrative Officer and the executive sponsor, along with Sabrina Robinson and Angelica Almeida, so our COO and our CIO for our workplace violence prevention strategy. So unlike the other strategies, we did not actually change our problem statement or our metric, and that's because we hadn't met the goal. So in looking at that, we've really focused on, should we think about it? Should we expand the areas? But we wanted to focus our energies on our most high-risk areas, which include our ED, urgent care, psych PES, and med-surg, and our behavioral health center. So if you go on to the next slide, you'll see the run chart kind of showing that. So we had a pretty bad spike this past December, brought that back down, and have really been focused on trying to figure out the root causes for that. And so if you go on to the next slide, you'll see, based off of a lot of discussion with different individuals within the organization, a lot of research with the other hospitals throughout the country, we've come up with these countermeasures that we really believe will address the root causes of our workplace violence events. So first, we are revamping and redeploying our CPI trainings, our crisis prevention intervention training. So before, we've really focused on de-escalation, verbal and identification of behaviors that could potentially lead to escalating violence. What we have added is a physical intervention when necessary training for our staff. Secondly, we've are really working to identify and standardize best practices across campus related to workplace violence and security. In particular, our COO, Sabrina Robinson, is working closely with Director Basil Price on implementation and prioritizing items in our security risk assessment so that we can improve our physical plant of the hospital to make it more secure. So things like weapons detection systems, cameras, and such. Additionally, on our third point, we've been identifying tools and assessing and stratifying potential assessments related to risk. So this again is really reaching out to other healthcare organizations, other safety nets throughout the country to see how they are proactively identifying patients and others who might be at risk of physical violence to our staff, and making sure that we've put those tools in place within the EMR. And then we're also making sure that we can have, if that person's identified as a potential risk, that we're communicating that risk to everyone who might be involved with that patient or that family member. And then lastly, we're really focusing on communication with staff. So, one of the things that we hear from our staff is that, what are you doing about it? So we want to make sure that they know what we're doing about it by making sure we're closing the loop on every single SAFE report that is submitted related to a workplace violence event, no matter how big or small, so that they realize that no matter what they report, it is important to us, and we're going to take it seriously, and we're going to work really hard to address it. So that is a kind of a quick rundown of our work and a kind of our expansion of work and the countermeasures related to workplace violence. So I will turn it over to Eric Wu to talk about finance.
Good afternoon, Commissioners. Please bear with me. I think I might be losing my voice a little bit.
My name is Eric Wu. I'm the Chief Financial Officer, and I'm excited to bring to you today our updated A3 with the catchy new title, Revving Up Revenue to Improve Our Care. I'm happy to co-lead this work with my partner, Dr. Pinzaria, who's our Chief of Performance Excellence. You'll see our problem statement up there. So for the past 2 years, we've been tracking the denials rate. And for this year, we wanted to expand our strategy and also monitor 2 additional key components of the revenue cycle: the time it takes for us to collect our revenue and the total amount of revenue collected. So this year, we've added 2 new KPIs, as you'll see on the screen: days of in accounts receivable. So this will essentially measure the efficiency of our claims process, denials management, billing accuracy, and collections. So lower AR days essentially means claims are being processed more quickly. As a reference, the median AR days for safety net hospitals is about 62.7 days. So you'll see our baseline at 61 days are actually already better than the median. The top 25% of all hospitals in the nation is about 50 days. Our realized revenue percentage metric, our percent, will be used to evaluate our revenue cycle efficiency by measuring the proportion of billed revenue successfully collected. So essentially, the higher amount, the better it is. There's no real industry baseline for realized revenue, since every hospital has a different sort of payer mix. So how we set our baseline was essentially using the 4.5 years of Epic data since we went live. So this metric will allow us to measure actual performance improvement that's distinct from expected and routine increases due to increased charges or reimbursement amounts. So you may be wondering, as you're looking at this chart, why are we only proposing a 0.75% increase? That seems like a really small amount. So ZSFG bills approximately $4.7 billion in gross revenue a year. So what that translates to is 1% of revenue equates to about $47 million of additional revenue that would flow to the hospital. So a 0.75% increase equates to about a $35 million increase in hospital revenue. So lastly, we plan to continue to monitor our primary hospital denials rate, as we have in the past, to continue to allow us to identify system issues such as coding errors, payer policy changes, authorization challenges, and documentation deficiencies, which all can lead to denied claims. So over the course of the year, ideally what we want to see is AR days decreasing, which will indicate faster claim turnaround and payment, which suggests more complete claim submissions to our payers. We'll also want to see an increase in realized revenue percentage, which demonstrates that we're properly documenting the care that we're providing to our patients, which then leads to higher claim reimbursements. Lastly, we'll also want to see, ideally, a decrease in our denials rate to assess the accuracy of our claim submissions. So a lower denial rate essentially means that claims are being submitted with more accurate coding, proper documentation, and alignment with our payer requirements. Looking at the KPI run charts on the next couple of slides, so we're seeing an opposite of what we want to see happening. So you're seeing increase in AR days, decreasing realized revenue percentage. So that was a great question. So to answer Commissioner Chow's question that he shared with us last week, I do want to point out that these trends can be typical and expected, mainly due to the holiday season. So factors such as staff vacations for the holidays, changing coverage during the beginning of the year. Oftentimes we have patients whose coverage resets can lead to some of these issues and slowdowns on processing of the claims that we're seeing on both sides. So typically, we expect to see the recovery of delayed claims wrap up starting in March and improve, with our strongest months being April through June. Other factors which are less typical that are contributing to the trends that we're seeing are some system issues related to the recent go live for BHS in Epic. And also, there's some system updates that were made that are delaying some of the claims. Most of these issues, fortunately, have been resolved, and the staff has actually submitting all the claims that were lagging, which is approximately about $12 million. So we should start seeing the fruits of these efforts posting over the next 30 to 45 days. Moving to the countermeasure summary. So our first countermeasure is to reduce pre-claim denials in patient access. So what we're looking here to really deploy resources to ensure that patient registration is captured correctly up front. So accurately from the front. So we're making sure that we're capturing patient demographics, their date of birth, and all the insurance details at the point of entry, so that the claim does, so we have accurate information just moving through the entire claim process. We're also looking to automate real-time eligibility checks. So when a patient comes in, we determine that they're eligible for services at the hospital. This countermeasure will help address authorization bottlenecks by obtaining necessary approvals before services are provided to our patients, and also enhancing our staff training to reduce claim delays. For our second countermeasure, it is to standardize the claim documentation process. So what we're looking to do is to implement structured workflows with checklists and standard work to ensure that all necessary denials are captured in the claims process and to minimize documentation errors. This will help improve accountability by establishing clear ownership of who's responsible for what documentation responsibilities. We're also looking to leverage Epic tools to flag missing information before a claim is submitted to a payer. Our third countermeasure is providing monthly provider training and Epic tools. So what we're hoping to do, and we've actually started to do this, is to offer provider training at least once every 2 months. We believe by demonstrating how CPT codes and documentations affect reimbursement using real-time data that we're seeing in the system, it will help improve our clinical documentation, which will lead to more accurate coding, reduce denials, and optimize reimbursement for the hospital. We're also looking to partner with IT to use Epic Insights for real-time analytics to help inform decision-making and improve communication between our providers and our revenue cycle teams. Our fourth countermeasure addresses automated authorization within Epic. So we're hoping to reduce the manual work and inefficiencies by working with our health plan to determine if we can automate prior authorization processes and improve turnaround times for payer approvals. This will help us minimize billing delays while increasing patient and provider satisfaction by helping streamline workflows and reduce delays in providing care to our patients. Lastly, we're looking to refine our financial stewardship True North metric. This is not really a countermeasure per se, but through our strategy work, we're looking to replace the general fund True North metric with a more actionable financial stewardship goal that will proactively drive meaningful financial improvements going forward. So currently our general fund target is a gauge of our financial performance as we close out the fiscal year. But there are several nuances in the general fund amount that does not truly reflect our financial performance for the hospital. So our goal will be to shift the focus to a more proactive financial management by setting clear objectives that guide decision-making and help enhance our financial outcomes. So Commissioner Green, you also sent a couple of really great questions I want to be able to address. Your first question was, how is AI going to be used to or is AI going to be used to generate suggested CPT codes at ZSFG? So ZSFG has looked into ways how we can integrate AI to support our revenue cycle. So I think a lot of what's happening in the AI space, it's still in a pilot phase. So Epic has rolled out some tools, from my understanding from patient financial services, that are limited to really drafting appeals letters to Medicare for like medical necessity denial. So essentially, we have a tool that there is a tool in Epic to draft a letter crafting why these procedures and services were medically necessary. So that's what we have available in Epic. And our HIM and coding team use a software called 3M Scrubber. So what that does is essentially a software that helps identify coding errors before they're submitted to the payer. So if there's any discrepancies between the medical record or any documentation issues before we submit the claim, it's essentially designed to just scrub the claim and review for any clinical documentation coding errors to ensure compliance and accuracy before a claim is submitted to the payer. You also asked about data collection or collection rates after 60 days and when are accounts receivable essentially written off. So our patient financial services pursues all claims for maximum reimbursement until they're fully resolved. So what that means is we appeal. So there's first level appeal, there's a second level appeal. And that can really extend the age of an AR way past 60 days, but we continue to appeal until that claim is resolved. So as long as an appeal is timely filed with a payer, payers do not reduce the reimbursement amount. So some appeals do get overturned a year later, and we do get the full amount paid in full. So in most cases, ARs are not written off until after we exhaust all means of collecting payment from the payer. As far as the time period, so payments can be denied or reduced by Medi-Cal if they're more than 6 months delayed. So my understanding is if we submit a claim more than 6 to 9 months after the date of service, our claim amount is reduced to 75%. After 10 to 12 months, our claim amount is then reduced to 50%. And I'm not clear on what happens after 12 months. I assume that claim is not paid. So there really is not a finite time period in which accounts receivable is cleared. Essentially, we look at it on a case-by-case basis to make sure that we're fully aligned with our billing policies. You also asked us to remind you about the payer mix associated. So our payer mix is approximately 60% Medicaid and about 30% Medicare. The 10% is commercial payers. So by and large, Medicaid and Medicare are our largest payers at the hospital. Does the health plan require different authorizations other than Blue Shield? Yes, so the health plan does require authorizations based off CPT codes, which is different than Anthem Blue Cross Medical Managed Care, which does not. So one of our countermeasures is really to work with the health plan on finding ways of how we can streamline the process to ensure there's not delays or bottlenecks in the claim approval process. And your last question was about any outlier payers at ZSFG that demand more authorizations or decline more claims. So we need to do a little more research on the outliers. The health plan does require more authorizations, as I spoke to earlier, than other payers. So our denials task force meets twice a month to review claims and denial patterns that we're seeing in kind of the claims process and really closely monitoring any specific outliers that they're seeing. So far, I'm not aware of any major outliers, but I've asked kind of our denials task force to take a closer look to see if there's outliers that we want to sort of focus more on. So that's my report for today. Thank you all for your time. I'm not sure who I'm handing it off to next. Oh, hey, Susan.
All right, I have the privilege of bringing us home with our work on equity. And equity is not really a strategy in the same way the other work that you've heard of is, but our goal is to incorporate equity into absolutely everything that we do. And over the last years, you've seen this work. We're not changing it in the upcoming year, but that's really, our focus is really on the PIPS committee. And Adrian Smith and Will Hewen have led this work over the years, and what it involves is coaching departments who are scheduled to present at the PIPS committee each month and helping them choose drivers for improvement that are focused on equity, as well as aggregating their data based on race, ethnicity, and language. And that work has been very successful. You can see that we're in the green here. Our target was 65% of departments having such plans, and our fiscal year to date, we're at 77.6%. It's pretty much the same as it was in 2024, and so we plan to continue this work over the course of the next year. Now I'm going to hand it off to Hemel to wrap us all up.
All right, thank you, commissioners, for letting us walk through our HOSHN for this past year. Again, this process has resulted in many successes over the years, which we're really proud of. Looking forward, the next steps really are to support the operationalization of these new KPIs and to support both our sort of strategic teams as well as our operational owners of that work. We will be returning to JCC with presentations on this, on each strategy in each detail, and then every quarter we'll be reviewing our True North scorecard with you all. So you'll continue to see these over the next year as well. So thank you, and we're happy to take any questions that you have.
Thank you. Thank you very much for such a comprehensive review of our strategy for the general for the next year. Thank you. Is there public comment?
There's no, well, actually, is there any public comment there? I think everyone here is a staff. No.
Okay, so we'll proceed with commissioner questions. Commissioner Green.
Yes, well, I would echo that. What wonderful teamwork and work. It's really remarkable the way you optimally utilize lean to really get incredible outcomes. I did have some more questions about the revenue cycle issue. And one is there are certain systems that reset the AR timeline to 0 if you resubmit a claim. So there may be some spurious data there. I wondered if you know whether that happens in the system or whether once the claim goes in, even if it requires resubmission or correction, it still clocks from the original submission date.
I'm not familiar with when or how the AR days reset, but I can get back to, I can work with our patient financial services team and get back to you on that, Commissioner.
Yeah, and then with the 90% Medicare, Medicaid, is it all managed Medicare and Medicaid when you talk about the percentages?
I believe so, but I can also confirm. I believe it's managed Medicare, Medicaid.
And then the last thing is, I know there's an AR scribe that listens and then recommends ICD-10 and CPT codes for encounters. I know that's available on the outpatient side. I could find out there's so many companies entering the space. It's like every week there's something else. And I think eventually one of the things we're all going to have to do is figure out when people want to refer to AI for medical information, which ones are the reliable ones. I mean, maybe Epic will incorporate something and we'll all end up with that. But I think UpToDate is going to be out to pasture, with the speed with which you can get information from AI. So it'd be kind of interesting to see how you choose and how this all evolves, especially with house staff or people who are pressed in clinic and have to get an answer right away. But I would be curious to know if really UC has something or there's, because you can just imagine if AI is giving you correct ICD-10s and CPTs, what that could potentially do for your all the extra work and manpower involved in following up with this. So I'd just be curious to somebody, it sounds like a great business model and use case. So somebody's out there's got to be doing it. And so I wondered, I'd just be interested to see what's going on there.
Great feedback, Dr.
Great,
Commissioner.
thanks.
Make sure we take it back to the team. Thank you.
Yeah, Commissioner Green, I just had a thought about that. So we're going to have our AI match with the payer's AI, depending on.
Yeah, I mean, I think there's great opportunities that we all have, during sort of our careers and lifetime to see the impact. And I mean, we're lucky to have a AI lab, the Prospect Lab, that we are engaging in all of our strategic work and increasingly over the next year. I think for the time being, we're focusing around length of stay, sepsis, and MOUD with them. And we recognize there's opportunities with our revenue cycle. And so I appreciate hearing about the additional ways that other health systems are employing AI, and I'm hoping that we can move in that direction as well.
Great.
So how is AI going to appeal another AI's decision?
Great question. I don't have a great answer for you.
Oh, they're great.
Well, it seems to me we got to get people back involved at that point.
Yeah.
We can't, it's just like, I think CMA said that, or the state now, that you cannot just give out AI information. This has to be through the physician who has then accepted or modified the AI solution.
I mean, I think we think about it, how we can leverage this tool, but as an adjunct to, a clinician helping with diagnosis, but the clinician is the person in front of the patient and it can help summarize information. So there might be opportunities for efficiency. And I agree that I think that humans and the human connection is going to continue to be an important part of practice.
I think it would be interesting as you're, and I guess it relates greatly to revenue, because that's where the denials are. Whether or not AI is assisting us, or are we then running into the other guy's AI that then, has less supervision, shall we say, and less motivation from a delivery standpoint. So Perhaps we could get something, as you're all working with this, maybe about a half a year from now, to say whether AI is playing a role for us and whether we're finding difficulties from the other side's AI. You're probably getting some denials from the other side from AI.
Great, thank you for that suggestion.
Okay. Commissioner Chris?
Yes, thank you. Thank you for this, the report, so clear and really easy to go through, a lot of information. So really appreciate the work that clearly went into putting it together. Just looking also at the workplace violence section, just want to express my gratitude for the continued focus on reducing the amount of workplace violence there is and the continued creativity and, not just accepting that there will be violence and this is just the way it is. And what can we do? What can you do to prevent it, understand the contours of it, to prevent and enable people, give people the tools for prevention. And where necessary to physically intervene. I'm really happy to see that you've gone in that direction because I know that's not the way that you think, right? And it's not the way that anybody in the helping professions thinks about needing to do that. But going to the places where the things that really need to be done ultimately in order to protect the workers, but also the people who are coming in to get help. So, thank you for that continued work on that and the continued creativity. Really appreciate it. I know it's not easy.
Thank you for that comment, and just lots of gratitude to Angelica and Sabrina for leading this work along with the high risk sort of areas. As an emergency physician, this is very top of mind to me during my clinical shifts. And I think, unless our team members feel safe in the work that they do, we can't really go beyond that. And so there's a lot of effort. I just add that we have been part of the Institute for Healthcare Improvement Leadership Alliance over the past 18 months. And so we get to hear from a lot of other health systems about sort of key issues in healthcare, and workplace safety and violence is top of mind to sort of healthcare institutions across the country. And at least in my experience in that leadership alliance, I think that's an area that despite our continued challenge there, it's also an area that we're really leading the way on and sharing what we're trying here, recognizing that we still have a lot of work to do to improve the environment and to make it as safe as possible for our team members, for our patients, for visitors on campus. But feel really proud of the work, and there's a lot of good work to come around that.
You are deservedly proud of the work, so thank you for it. Also wanted to kind of express my pleasure at this new antibiotic that exists and that's being deployed, because I know it's a huge problem for people, particularly coming in, people generally, and it is seen, it had been seen at least a lot or a fair amount in the incarceration situation. And so, people not being able to stay clean enough to prevent those infections. Can you just give a little bit more of information about that?
Yeah, sure. So, we probably, soft tissue infections are one of the most common diagnoses that we see in the emergency department that get hospitalized as well. And there are, of course, individuals who are, very sick with sepsis, with sort of bad infections that do still need hospital level care. But there's a pretty large cohort, as Dr. Ortiz was mentioning, that may not be systemically ill, but have very, very significant wounds that do require IV antibiotics. And so instead of hospitalizing someone for 3+ days for serial IV antibiotics, this allows us an opportunity to give them a single dose. And then what we do, because it's a new initiative, as with all of our initiatives, we're sort of plan, do, study, act. We PDSA it to make sure that we're learning from it, to make sure that it's effective, to make sure that it's safe. And so part of this trial has been a partnership between the ED as well as with the infectious disease and hospital medicine. And that means that these patients, we have follow-up in our infectious disease clinic. Many of them also go to our wound care clinics to ensure that their treatment is improving, because it's a newer sort of therapeutic that we're trying. But it's a great opportunity for us, again, for a patient population that is commonly part of the borders in the ED, commonly, on our inpatient units, that we're trying to maximize the use of those beds for patients that can't receive that care anywhere else. And so I'm really excited to sort of track our outcomes with that program. And I think that will be an opportunity where, again, we'll be able to share with and sort of add science and add to the literature so that other sort of health systems can benefit from that as well.
That's really exciting.
Yeah.
Thank you. And the final thing I want to say is just also commending you on the work that you're doing on boarding, and particularly my specific interest is, the psychiatric space. And I know that it's, impossibly difficult, but with some staffing changes that have been made, some appointments, but also just your continued work, it seems like you're finding ways to slowly slice away at the days.
Yep.
So, and are you finding that there are more actual beds these days?
So a multifold question. I would say that with all improvement work, and especially with these topics that we're talking about, persistence is a key attribute. And so we're lucky to have the team members you saw today and their teams who are always willing to sort of keep at it and chipping away. I think that's a really important part of improvement. In terms of beds in the community, so yes, there's been a lot of work both within the network and DPH and the city to recognize that our patient demands and volume and needs outstrip the current capacity of the system. I think also, like, historically, healthcare hasn't been set up for some of the things that we're seeing today. And so,
No.
again, historically, people went into emergency medicine to think about how to care for patients with strokes or heart attacks or gunshot wounds. I don't know that on the radar screen was behavioral health crisis. For example, we're so fortunate here to have psychiatric emergency services. Very few cities and systems can have that benefit. And the demand for those services right now is still significant, as we see in our community. And so there's still work to do. I would say one area that we need to continue working on is the match between the beds that are available and the patients that are able to accommodate and what our patients' actual needs are. And so that is not just unique to behavioral health, but patients with dementia, patients with traumatic brain injury, patients with both dual diagnosis, with both behavioral health conditions and physical ailments. Those are all examples of very common patients in our increasingly elderly society, where we actually, I don't think that we have, I think we need to, grow in that area as a city, as a region. This is not just a San Francisco problem. This is sort of like across the country, but we definitely see it manifest here.
Thank you.
Thank you, and I'd like to thank the entire team for an excellent presentation, and for actually, because this is Monday, it's really difficult, and I'm just amazed that you're able to provide us written answers also that are quite thorough. So thank you very much for your presentation, and we'll look forward to the reports as they roll out through the year.
Thank you so much.
Okay, let's move on to item 7, the medical staff report.
Good afternoon, commissioners and Mr. Moritz. I'm Mary Mercer. I'm the chief of the medical staff. It's great to be with all of you today. I'm very pleased to present our medical staff report, and I will highlight a few things and respond to some of the questions that came through in the email, and then take any questions that you have. So the first thing that we led off with was the ophthalmology service report, and like our other service reports, are really diverse and wonderful, both faculty and advanced practice providers that work with us. But things that I'd like to highlight is just the number of really significant performance improvement efforts that the ophthalmology service has really seen through that touch on all of the areas of our True North metrics. So access and flow, patient experience, financial stewardship, quality and safety. And a couple of these within there, just to highlight the teleretinopathy program,
where that came out of COVID, some innovations in terms of ensuring access for patients in the community that needed screening services, and we had the removal of the van, and now we have access in all of our community primary care clinics for this important screening services. Additionally, you see year after year, we've had challenges with backlogs of cataract surgeries, and we've really made significant improvement on decreasing that, both through lean improvement efforts in our OR on campus, but then also with partnership with Chinese Hospital to add OR time in a culturally congruent manner for a number of our patients. And then finally, the diabetic proliferative retinopathy program, where they really incorporated the patient voice and feedback from patients to really understand why patients who were at risk with diabetic retinopathy were missing their follow-up preventive treatments for laser treatments, and then going on to have complications of hemorrhage that would require much more invasive surgery. They incorporated patient feedback and reduced the time for the follow-up appointment, so less patients were lost to follow, and then they are seeing better outcomes in those patients. I'm happy to take any questions about the ophthalmology service report if you have additional ones. Additionally, with the report, there are a number of updates to their privileges and standard procedures. There are minor changes, and I appreciate Dr. Chow, your feedback and catching a few typos, as well as we'll make sure to have the redlined reports only. This one had just some minor feedback, minor changes on there. The other updates in the privileges and standardized procedures were for ortho, the medicine service, and GI privileges. And I'm happy to take any questions about those there, but they're pretty straightforward.
Thank you. Commissioners, questions? Commissioner Green.
Yeah, well, it was really a wonderful slide presentation, as I always are. It's so much fun to look through those. I submitted just one misspelling correction, and I'm not sure, I didn't see it on the list, so I wanted to make sure you got it.
Oh, thank you. Yes, we will get that and have that changed.
Great, good.
No, well, thank you. It was certainly a very extensive report on the department, which we appreciate. Let's go on to your other points then.
Great. I think that was for the ophthalmology service. The other changes were just some additions for the privileges and standardized procedures for orthopedics, which was adding an ultrasound piece, and then GI privileges for capsule endoscopy. And if there are, I'll take questions on those, but otherwise the next item is a separate agenda item regarding the chief of service nomination. So.
And if I can quickly interject, our new managing city attorney, deputy city attorney has advocated that any staff positions that you all interact with should be separate items. So in the future, instead of having it embedded in the medical staff report, you all will have, which it doesn't happen frequently, but there'll be separate items on the JCC agenda as we do today. And then in the full commission, it'll also be a separate item, just so it's kind of clear.
Okay, well, follow the city attorney's advice.
You know, it changes depending on who's in the seat. But right now we're on this item. So if you all
right, so we should be prepared here now for a recommendation to submit to the commission the changes as recommended in the agenda.
So moved.
Second.
All those in favor?
Aye.
Aye.
All right, thank you. And now we can move on to the next item, item 8, a recommendation to the Health Commission regarding appointment of the Chief of Urology.
Okay, wonderful. And there was a question, well, I'll start off. It was lovely to see you all last week at the Health Commission, where we presented the Chief of Service recommendation for our psychiatry Chief of Service. And again, and aligned with this change to for the Deputy City Attorney, we wanted to really tighten up our standard work for our nominations for the Chiefs of Service. And in this case, we're presenting what is our new process and in a new template that provides you, so I'm spending a little bit more time than I otherwise would, just explaining the new template, why this looks a little bit different from what you saw last week. We have a letter of recommendation for the appointment from me, and then on the following page, there is a summary which includes, instead of a full, sometimes 40 or 50-page CV, we're including a brief, less than 5-page summary that includes highlights of the Chief of Service's career with a bio sketch that summarizes their, education and their accomplishments, and then highlights some of their awards and notable articles or service, so that as we move through the process, a much more abbreviated packet goes to both you and to the Health Commission and highlights the key points that are relevant here. So I'm happy to take questions about the process, and then I'll move on to the recommendation of this particular candidate.
Commissioners, questions?
Another incredible person, as always.
Yes.
Well,
So
we don't get his 15-page CV.
I would be happy to send it as an appendix, and this is why we wanted to give you feedback, and you just saw the full CV last week of someone else. We're sharing an abbreviated one. I'm happy to share that as an electronic appendix if that's something that the commission or the JCC would like.
That's something that I would like.
Okay, we can definitely send that.
And I'd actually recommend that we take out personal contact information. I didn't say that before, but that the whole world sees that forever, and we don't need that for a person.
Sure. Matter of fact, many of the CVs really don't carry that anymore. But very good point. The summary is very nice, but I think if you send a file regarding it, it is helpful to be able to look at the extent of the work that somebody has achieved. So are you going to tell us about the candidate? Well, you were going to tell me that the exec committee did not meet on August 12th yet, right?
Yes, so we did, in fact. So and this is notable. So Dr. David Bain is one of our exceptional urologists, and he has been serving in the interim role as the interim chief of service since Dr. Benjamin Breyer, who was our prior chief of service, became chair of the Department of Urology for UCSF. And at the same time, we had our changes in multiple city departments, including with our colleagues at the city attorney's office, and we're working on this improved process for all of you. So while the search committee conducted a national search and recommended this internal candidate and had a provisional offer, the formal process hadn't really moved out of the MEC to all of you formally until today. And so we apologize for that delay, but we wanted to make sure we got it right.
Okay, but you didn't mean August 12th, 2025.
Oh, I'm sorry. Yes, we meant 2024. Thank you. But it was August 2012, August 12th, 2024.
Okay.
We will update that.
No.
Thank you, Dr.
All
Chair.
right. So he actually was interviewed for the interim position in August, and your search committee then found that our internal candidate was really the best that they would select and recommend. Okay.
Exactly. And so, as noted, Dr. Bain is really an expert on a number of urologic conditions, including urologic trauma, and particularly around kidney stones and urologic obstruction. We're really lucky to have him here. He, in addition to this role as chief of service, he also holds an important role in our training program at UCSF School of Medicine, training the residents in a number of different simulation and other aspects of urologic surgery.
Okay, any questions regarding the candidate? Is there then a recommendation for the commission?
So moved.
Second.
All those in favor?
Aye.
All right, thank you so much, Dr. Mercer. We can move on to item 9, other business. Hearing none, we can move on to item 10, public comment. I don't believe we have any public in the room. And so we can move on to a consideration of a closed session.
Motions in order for a closed session?
So moved.
Second.
All those in favor?
Aye.
All right, please give me 30 seconds to take us over.
I know.
Commissioners, you have approved the credentials report and PIPS minutes in closed session. Please make a motion to disclose or not disclose other discussions held in closed session.
Move not to disclose.
Second.
All those in favor?
Aye.
Aye.
And please consider a motion to adjourn.
Move to adjourn.
Second.
All those in favor?
Aye.
All right. Thank you, everyone.
Thank
you.
you, everybody.